pretty good start to 8 months with them. So I think you should take a curtsy before you sit down.
Sorry, guys.
Okay, we called the meeting to order. And Lori and Sherry and Greg are present. We did the Pledge of Allegiance, and there's no call to the public. So 1.5, approval of previous minutes. We'll have to table that because I haven't received them to even read them. Have you, Paul? So we can't.
They're all on board docs. They're all online on board docs.
Oh, okay.
They're all just the recording.
Okay. Well, we'll have to listen to those.
So the
to be
new
able to
format,
approve them.
with board docs is that they're all digital and available for you to review, so they're in their entirety.
Probably we should be told that before we come, so we would listen to them.
Good point.
Yeah.
And how do we get there?
I know how because I'm a board member, but these two
See,
would not know
we are
how.
not.
That's
Yeah.
our fault, because we
Yeah.
made the assumption, because both of our boards are aware, we assumed that you were, and obviously there's no reason for you to be, because it's a brand new system that we just implemented.
And we don't approve minutes anymore.
And we don't approve minutes anymore because they're in their entirety.
Yeah.
The whole recording is on our website, but we can table that. for
Yeah,
tonight.
let's table that. Okay.
But
Two.
can we at least, so we can,
We're gonna get you
Yeah.
access. We'll get you
Yeah.
access.
Kim will do that.
2.1, ASBIG, report update.
Thank you, trustees and Madam President, I appreciate it. School representatives, thank you for being here. Thank you.
There you go.
How's that? I'm still a tower over it, unfortunately, so. It is on, I believe it's
Oh,
on.
there you go.
Yes, there we go.
Thank you.
I'll just talk a little bit louder. Again, wanted to cover the reporting from February of 2019 to January of 2020. If you can flip to my presentation. It'll be the middle one.
It's the middle, right?
Thank you very much. And if you go to the fourth page, we're going to actually jump right into it, into the key findings in memory utilization. Again, this is your utilization for both schools, for Colorado River and for Bullhead City. When you look at overall claims, they're actually trending up 41%. And we'll go over some of the numbers here in a little bit. Professional claims increased 60.3%. Inpatient facility, again, that's going to be your, if you're hospitalized, that's up 83.1%. And then outpatient, so that's your outpatient surgery, MRIs, anything like that. Outpatient facility claims increased 96%. The only thing that's actually on a downtrend is your pharmacy claims, which has gone down 22.7%. Currently, large claims over 50,000. You've got 14 large claims that are over 50,000. Of those 14 large claims, 4 of them are over 200,000, and then one of those large claims is 1.5 million. And then your emergency room usage, overall number of ER claimants 83, total amount paid 289,707. You did have one member who utilized the emergency room 10 times. Again, I know we've talked about this. Again, it's an educational opportunity. If they don't have anywhere to go, if they can't go to urgent care, if they're not calling teledoc, I guess that's all they have is the ER. But there should be some sort of direction that they can go that they don't have to go to the ER 10 times. So you would think that's a little bit overkill. But at the same time, again, not knowing what the actual claims are, you know. If we look at the loss ratio report, again, January claims at the far right, actually, yeah, far right. You're up 135% loss ratio. So the trend is 109.87. So again, claims really hit you hard in January.
Chuck, is that typical?
Typically, I see actually a little break in claims in January. That's a lot of claims.
Yeah.
Usually,
That's
we
not
like
normal
to.
for us.
Pardon me?
That's not normal for us, for January.
For January, yeah, they're probably normal for you. Typically, though, benchmark-wise, I see a lull in claims. And that's why we like to utilize January when we figure out what our overall rate increase is gonna be. We go from February of 2019 to January, because typically January is a low claim month. So this, this is definitely out of the ordinary, for sure. The next page, expense by service category. Again, you'll see these are the same from the key findings of page 4. At the very bottom, you'll see that you're trending up. I've marked it in kind of an orange box there, 41%. But then you've got your outpatient facility at 83.1. Your inpatient at 83.1. Your outpatient at 96. Your professional at 60, and then your pharmacy. Management services are pretty much even. Management services being your nurse health coaching, case management, disease management. That's where you get in for the management services. So again, claims are trending up, unfortunately. Here's your high cost claimants. This is your top 15. Again, 14 of those are over 50,000. So just your top 15 claims, you're at $3.4 million in claims. And that's not all of your claims. If you go back to the other page, if you scroll down, actually scroll up, there you go. Keep going. Your total claims for February of 2019 is 4.6 million. So 15 of your folks are taking, are accounting for almost all of your claims. So, which is incredible. So it's just a lot. The next page is your emergency room report. Again, 83 visits. Actually, your ER visits are down. You've just had a couple folks that continue to use the ER greater than 10 times. So last year you had one that used it 11. This year it's been 10. So again, maybe it's an education to send out, communication piece to be able to send out to the employees about teledoc, about urgent care, or about scheduling appointments with their primary care physician. A lot of times when we see folks that are utilizing the ER so many times, they don't actually have a primary care physician. So they, for some reason or another, I don't know why, but that's what we find a lot of times. Renewal rates. Do we want to talk about the renewal rates yet?
Sure.
Okay.
Jump right in.
Yeah.
Jump right in with the lovely news.
Yes, so
Oh.
So.
renewal rates.
No, he can just, while he's talking, you might as well tell him. Give
Yeah,
him a-
renewal rates, they came in at 15% increase, which actually is our cap. We cap our renewals at 15, so they don't go over. So folks that are running at 135% or higher, that would typically have a 25 to 35% rate increase. We want to make sure that we cap those off. So we cap it at 15. So that's where we're at right now. With the plans that you currently have. Now we do offer 9 different plans that you can pick and choose from. And there are certain plans that we could put in place of the plans that you have right now that might bring it down to 11%. There's even a scenario that I ran that brought it down to 6.7%. So there are options when you look at all the different plans. The Classic Silver is your most expensive plan right now. I would suggest bringing that down to the Value Gold. I would go Value Gold, Value Bronze, and then put in a high deductible health plan, possibly the 3,000. And that should bring your rates down to 8.7%.
So say again, please, which ones you're recommending?
The Value Gold, the Value Bronze, and the 3,000 high deductible health plan.
And that would bring it down to
8.7.
8.7.
And again, there should be a rate sheet that y'all have too that kind of goes over the benefits of those different plans. Value Gold being a $750 deductible. Again, when you look at the private sector, Deductibles are in the 1,500s to 2,500s, right around there. Obviously, we want to have a retention and a recruiting tool when it comes to your healthcare. So a $750 deductible is still a very rich plan when you look at all the private sector businesses that are obviously offering a much higher deductible. At the same time, again, going from $500, which is your classic silver, to a value gold of $750, that can be a little bit of a big jump, and it's going to be an education, and it's going to take some education, which basically means employee benefit meetings, going out, answering questions, and meet with all your folks, and just making sure that they understand the plans. The Value Bronze plan is a $2,000 deductible plan. So you're going from a $750 to a $2,000 deductible. Again, you could keep in the Value Silver, which would be a $1,000 deductible, but I'm going off of trying to save dollars for the district and for the employees. And then put in a high deductible health plan for the folks that want an HSA. And that's a $3,000 deductible. It's not good news. I mean, I can't sugarcoat it. I can't come up here and try and make it look pretty. It really isn't. Claims are claims, and it's the unfortunate fact.
Except for when our claims were lower, we still had an increase. That's the hard
Everybody
part
gets-
that's hard for me
right.
to swallow.
Sure, I
is
get
when
it.
we
I get
had
it.
the lower claims, you still raised our rates. So that's
Everybody
what's
gets
hard
their
to
rates
swallow.
raised. I mean, medical trend goes up
Well, I
9 to
know, but
11%.
it's when you have a decrease in your claims shouldn't rise.
I get it.
Because you take full advantage when our claims are high to raise our rates, but when our claims dropped, no one kept our rates the same.
Right.
That's
Right.
what I expected that year, and
Right.
then it was like no. So it's just like raise them, no matter what.
Sure.
So
I get it. I'm
And that's
with you.
kind of discouraging.
Everything goes up, and yeah, it is discouraging, absolutely. Especially when we look at where the rates are right now. So it's absolutely discouraging. So,
yeah, I mean, and
like I said, I
and
want to be able
it's
to.
not it's not reasonable to expect a teacher to pay a $2,000 deductible. I mean, it's just,
They're only
it's just
hitting
not.
they're only touching that deductible if they're hospitalized, or if they have outpatient surgery, or if they're going to get an MRI. If they're just going to the doctors, they're just paying copays. If they're going to get a prescription, they're just going to pay copays. They'll never touch that deductible if they're
Until
not
they have to.
hospitalized. Well, until they have to. That's exactly right. So that's what I have. I want to be able to work with y'all. That's why we have the 9 different plans. It might not, you might not want to change the plan designs, and that's your prerogative. At the same time, I want to be able to work with you to find something that does work.
Okay,
Okay?
thank you.
And I appreciate it. Thank you very
Madam
much.
Chair, a couple of questions.
Yes, please.
Okay, somebody who couldn't be here asked me to ask these.
Sure.
Of all three of you. Okay, so, is there such a thing as a price break for dual employees? So we have spouses who work for the district.
Right.
Is there anything that changes relative to the rates? I don't quite understand how that works, so I'm just asking you the way it was asked of me.
Well, if you're funding for the employee, and they both, instead of going on to a plan as employee spouse and paying for that dependent, they would go on as each employee, and then so the district would be covering their premiums for them. So that is a huge benefit for the employees. Absolutely.
Is there a price break? We have both employees working for, they have dependents. And is there a price break
So, okay.
when they have to claim those dependents on?
Right.
There
No,
used to
there's
be.
not.
There's not.
There's not.
Because
There used to be one.
at some point, they got a discount on it.
Yes.
Yes,
When
we
they had
did.
dependents, because I know, I been paying it
Right,
for
right.
years. You had dependents, and if it was a dual spouse.
Right.
Yes.
Even if they were each other's district,
Uh-huh.
they combined them, and there was a discount rate for it.
Yes, there was.
And at some point that went away. I don't know when it did,
Right,
but
right.
at some point that did go away.
And that's why I was asking.
Sure.
Ask you the question.
As of right now, what I see, and for this year that I've taken over, there is no price break on that. There is no difference on there.
Thank you. Okay, the second question is, so if the trust were to choose your plan, is it a 1-year plan, a 2-year plan, a 3-year plan?
It's a 1 year,
What is it?
1
It's a
year,
1-year
12
plan.
months.
Okay. And John had another question, I think. I'll ask it for him,
Okay.
so that I'm sure we ask all three. Okay, so if somebody goes to the hospital,
Right,
and the hospital is in-network,
right.
are then all of the providers in that hospital also considered in-network? Or can they bill you separately, like the anesthesiologist or the surgeon?
You
Are
can,
they in-network automatically, or is it a separate thing?
you can get surprise billing like a hospital internist, or a hospitalist, excuse me, can come in the room and still end up charging you. And they aren't part of any network at all. So, you know, it really depends. What we try to do is if it's in a hospital network and the billing is coming from the hospital, everything's gonna be is paid in network. And we'll work with them in regards to those out of network bills that come in. Because it does happen, they're gonna get a bill from somebody and then it's gotta go through our process to where we can actually bill it in network.
Yeah, because if you're in the hospital, you have an X-ray.
Right,
Your radiologist reads the X-ray.
right,
You have no control over that.
that's right,
You can't say, oh, I'm in my network,
right.
you know.
And
They read-
that's what we were having happen actually quite a few times with Radiological Associates.
And that's taken care of.
Right, and we had to get them contracted, so yeah, so it does happen.
So, yeah, would they be expected to be responsible for those?
In a hospital situation, you would expect that everything's gonna be in network, because you don't have, a lot of times you don't have a choice.
Correct, we have 2 hospitals, you
Right,
know.
so in an emergency situation, you're gonna be covered in network regardless, and we're gonna fight that.
Non-emergency?
Not emergency, well, if you're being admitted into the hospital, I guess except
For
for
a
outpatient.
gallbladder.
For what?
Just because you need your gallbladder out. That is non-emergency. You have the ultrasound or the.
But you don't have any control.
You have no
You're having
control.
it done.
But
I've
you're
had
gonna
to
get a
write
bill
numerous
from
letters.
somebody.
You will, but
You'll get a bill from somebody.
If you write a letter
Somebody
and say,
walks in,
you know.
somebody walks in the door to check on you, and they're out of network, you're gonna get a bill from them. You send it to us, and then we're gonna
Okay.
work with
What they
it.
need to know is that they can send the bill to
Right,
you. Okay.
That really answers my question.
Sure.
You fight for our.
absolutely,
for our-
absolutely.
Thanks, John.
You're welcome. Any other questions?
Yes,
Is it okay if I ask one?
yes.
Yes,
Great
please.
protocol. What about the person that's on call that never actually walks in your room and you get a bill from them? That happened to me a couple years ago. I never even saw that individual and they were on call when I was in the ICU. That's it.
So they're the on-call physician. It's in network, but the hospital was, the
The
ER
hospital
was in network.
I'm in ICU. I get billed for a doctor that never even entered my room or saw me. Didn't even hear of them until I got the bill.
Yeah, that would be something you'd wanna fight, for sure.
That happens a lot in this area. Just tell me. You never even see them, and all of a sudden you're getting bills from them.
Well, it was a
You
huge
probably
problem.
called an order in.
Someone called him, yes.
Any other questions?
Yeah,
Well, I appreciate everybody's time. Thank you very much.
thank you.
Thank you.
Emeritus report update?
I don't think there's anyone here.
Yeah, I don't think those guys showed up.
I didn't-
Okay. Vision Care Direct? No? Miscellaneous update? All right. Kairos?
You'll need to press this out.
Wait, put them to work.
I think you guys are friendly.
Yeah.
Well, there's no other way to be.
Exactly.
Wow, these kids are crazy.
Would you go with the? Perfect. Yes. So here are gonna be the rates, but I just wanted, can I back up just a little bit on some of the questions that he had received?
I would give them to you anyway.
Oh, okay, perfect. So and trust me, do I think that Kairos is the great, I'm biased, I think that Kairos is a great program, but some of the things that you would what is your name in the back? What's your name? Gina. So one of you had a great question, and it's actually one of, I call them the war stories that we go through when we're sitting here on the insurer's side and we're trying to pay out those claims. We see those types of stories all the time, and it's what's wrong with this area, but in general, what's wrong with healthcare in throughout the state. So, for example, we had a member, a teacher, kindergarten teacher, went to the hospital because they just split their head, and it was 8 stitches, and I think it was her kid. They went to the hospital, and just like you said, the facility's a network, right? And so they know that, they go into that facility, and all of a sudden they get a bill for $347,000. And so obviously we've looked into that, right? And we start digging through, and it was for a head laceration, 8 stitches, and it should have been around, they said $5,000 was the usual customary. They charged whatever they wanted, right? They charged it because he said, I'm just contracted, I'm not in network. I don't, it doesn't matter if it's ASPAID, if it's Kairos, if it's Blue Cross, if it's United, who it is, they don't contract with anybody. And so they did that. So what we did was we went and wrote a letter saying, you realize these are school districts, and all of a sudden the PR part of it scared them, and they knocked that bill all the way back down. But that's part of the problem with healthcare in general, is that all these bills are coming in. So when Chuck is saying, we have to raise our rates 15%, that's what he literally has to raise your rates in order to cover the costs, because we're getting bills like $300,000 when maybe it should have been $8,000. Or we had one at the Las Vegas hospital that was supposed to be an $18,000 charge, and the facility charged $800,000. And what they did is they enticed the employee by saying, we'll cover all your out-of-pocket expenses as long as you don't bill through Access or you don't go through. So even though it helped the employee out, what they did is they billed the plan back $800,000, which hurts the entire 59 districts that are in the pool. So it's things like that. We have to start to tackle the actual problems with healthcare, and until we do, we're gonna see rates that continue to climb. So that's why we always say, employees, if we can look at the EOBs, like you guys are the first line of defense, so if that kind of stuff happens, we have to know about it so that we can start to tackle that. Because even though your expense might be, whatever your deductible might be, $1,000, and then the plan on the backside, the school district, when they're seeing 37% loss ratio, that's because they're still billing the plan in the school districts that all own ASBAID, Kairos, whatever pool it is. They're all billing them, and that's what makes our rates all go up. And so if we can start to get people to call in and let us fight for those are the ways that we can try to at least get a hold of the monopolies that try to just bill whatever they want. So as much as I think our plan is better, I understand that sometimes we just see bills and stuff or physicians that are outrageous or they're egregious billing. And so we're all about, we even want to start an incentive program. If we can find those types of bills, it saves all of the school districts who own ASBAID and Chiron, it saves them so much. Can we start to incentivize by giving a % of savings back? So we're not there yet, but we're starting to think about those things so that we change behavior from the employee side too, because we don't know until 3 months later when the employee gets to at least, or sees those bills. So it's a lot of education on our part to try to educate the employees on, hey, these are what you're looking for when you're looking at your explanation of benefits and stuff like that. But I thought that was a good example because we see that kind of stuff all the time, and it's just a huge problem. It's robbery.
Well, they were sleeping on the cot their entire shift, but you still got billed for them.
Right,
Yeah.
right, and you try getting the data behind it. So if I call and say, give me that example, can I see the itemized list? Oh, no, we can't give that to you. Right? You can pay it, but you can't see what you're gonna pay it for. It's absolutely ridiculous. So those are really good examples, and that's exactly, it's not the onesies and twosies, it's not all of the going to the doctor, it's not going to urgent care. Those aren't what drive those claims up. It's what did you say? It was like 15% of their people it's this many of your people are.
Oh, right, exactly.
Are you have to pay for this many of the claims. So 90% of your claims are getting paid by your top 3 or 4% of users. Well, that's because when we're paying things like $397,000 or $347,000 for 8 stitches, that's what drives up those prices. So I love that example because that's exactly what we got to start fighting. So I had to start out with that one.
Well, it's like
let me get off my
we
soapbox,
send a
but
lot
it just
of
is.
people to Mountain Imaging in Kingman because their fees are so much less to get a CT at any hospital. You know, it's thousands of dollars. But it's like $400 there. But guess what? Kingman Hospital just bought them and shut them down.
Yeah, that's
so
exactly.
It's like,
that's exactly. They're all buying them up, and so the pharmacies are the same
we send
way.
people there all the time. We send so many patients there. We get stacks of their cards all the time. But interestingly enough, my husband's a foot doctor in town, and he takes foot X-rays all the time, $60. But I had to go have hand and foot X-rays taken. But my doctor wanted the big film, so my husband has digital X-rays, so I couldn't do that. $472.
We need to directly contract with your husband.
$472 for my foot X-rays at the hospital.
Okay, so
that would have cost $60 at his office. I'm like, do you know how much I just paid for my foot X-rays at the hospital? And he's like
probably blah blah blah.
He's like, $300, and I was like, no, $472 towards. I go,
and that was just your share of it, I'm sure.
Well,
right?
I had to pay because my deductible is like, $5,000, so I had to pay big money. But
what's even worse is if you
just could have died $472.
If you ask them, here's the bigger problem is that when you tell a physician or a hospital, hey, I'll pay you in cap. Don't use my insurance, but if I pay you in cap, it's suddenly lower than if you had the insurance, which is a problem too, right? Because they know that they're not going to be able to stick you with a $347,000 bill. They know a teacher's not going to pay that because they can't. But if they can blindly charge the plan, they will all day. It's like a blank check, and that's when I call them the BUCAs, and if Blues, United, Cigna, Aetna, Humana, if any of them go and say, well, we'll give you a 60% discount, and then Chuck will be like, well, Aetna will give you a 65%. And then if anybody here asked us, well, 65% of what or 70% of what, we'd be like, I don't know. Like it's ridiculous the way it works, and so we have to start to change those things. So if we went to your husband or like a physician's office and we said, hey, we want we have a core group in the state that are all together. We want to be able to directly contract with you all, and we want you to know up front what you're going to pay, because that's how we buy everything else. Even if you get duped or you get hosed at the car dealership, at least you know the price when you're driving away, right? So it's just frustrating because a teacher has to go march at the Capitol in order to get a 10% raise on their salary, yet we just throw away $347,000 to a physician.
Not to a physician. They cut the physician.
I'm sorry.
All the time.
Well, I'm saying the facility.
Yeah,
right?
Facilities get the money, not physicians.
Well,
they cut our fee all the time.
No, but the physician on call, that's saying like, oh, it's we contract separately. We're like a contractor. Those are the ones that'll really get you. So like the anesthesiologists and those things. So if we can start to direct care and steer and incentivize our employees to go to those places by saying, if you go there, it's $0 because it saves the plan so much money on the back end. But we got to get there, and it's just we're working to get there, and it's really hard to fight the industry.
When hospitals are buying those places,
Yep.
like Mountain Imaging, where you could go get a CT for $400.
Yeah.
We would send people there for an MRI for $800 instead of $5,000.
Right.
For under 300 cash in Vegas, I just did it.
Did you?
See, and that's what I'm saying. Cash is,
MRI.
and then if we can figure out a way to reimburse that
place, because we send people all the time where it's cheaper. Steinberg Diagnostic?
Yeah, they have
Okay.
like a dozen of them in Vegas.
Okay.
They also have slots and poker there too.
No, but we have people who can't afford to pay $5,000 at one of our hospitals for a MRI.
I know, and the flip side of it is, so I sit here and I was just talking to new HR personnel and talking to them about how to communicate, because this stuff is too complicated. We have to simplify it. We have to figure out ways to make it a little bit easier for employees to understand. Even though we're working in this complex mold, how is it that we can really sit down one-on-one. How do we create more time? Where are the resources? Things of that nature. And one of them, and I swear to you, it was the worst. It was so sad. She worked in payroll, and she goes, I have families. I have teachers that are families, and I have to literally adjust pay every 2 weeks, and because she owes the district money after healthcare gets taken out. So she has negative dollars left after she pays her family rates. And I'm sitting there saying, so Kairos and all pool, as soon as it's like your own bank account that you're part owner in. So when claims are coming in, we're just taking that money that's in there and we're paying them right back out to pay all those facilities. Now you have your, networking fees and the pool administration, which is, 9%, but 91 cents of every dollar is going to pay for those claims. And when we get the claims like from Las Vegas and from Kingman and stuff, it's horrible for the employees. And the worst part is that we're paying them out too on our end. We have to raise everyone's rates in order to cover those claims. So it's the hard part about living in the rural area, but it's also a good part about being part of a pool, whether it's an ASBATE pool or a Kairos pool. At least you're sharing that risk with the people that are in Maricopa and Tucson and different areas, because that helps you keep those rates back down. But until we get a hold of claims costs, we're dead in the water. And all the school districts in the state are the same way, because there's not a school in the state that can afford to continue to raise budgets 10%. And there's not employees have gone up 78% in their contributions, and their wages have gone up 26% in the last 8-9 years. So it sucks. It just sucks until we can start to fix the industry. It's a bad. We got to get a hold of it. That's the only way we're going to be able to. But I agree with that. So just so for our rates, I did give you guys just the plan, the comparisons. And I had to make some assumptions on the migration. And what I mean by the migration is if our core plan that you see up there is a $500 deductible, what is that the closest to on your what you currently offer? And so I matched them up as best I can. The 750 copay plan, knowing that would be one of the buy-up ones for the district, how many would go on there. I had to assume, and if my assumptions are wrong, I can go back on this too, but I assumed that the district would fund the $1,500 high deductible health plan, and that's because it's the closest to the actual rates, and it is a little bit different, but it's a different plan in that it is a high deductible, so they are going to be responsible for a larger deductible than the $1,000. There are some breaks in there as far as like generic medications, stuff like that, where copays kick in right away, or telehealth, things of that nature, where it's a $49 copay until deductible is hit. But I had to assume that piece. Now, on the 2,500 and the 5,000, where if you see the annual contribution, my formula must have gotten messed up on that, but it should say 1,848 on the employee only annual contribution on the 5,000. So let's say an employee was like, hey, I know I'm 30 years old, I'm young, I'm healthy, I never go to the doctor. I'd rather go onto a way higher deductible and the district contribute, $1,800 or $1,850 to my HSA account, and that rolls over year after year. That would be something that they might be interested in. Now, it is not for everybody. In fact, it might not be for most people if they're going to the doctors. But the same thing goes for the 2,500. Obviously, it's not going to be as much, but typically what the district will do is they'll put the difference in the HSAs. So if they're funding the $1,500 plan and it's $818 for the school district, they would take then the difference between 818 and 770 or $777, and they put that into the HSA, and I think that's 41, or right around that, $40, about $40 a month. So those are just different scenarios. In total, if the district decided to fund the $1,500 plan, that's about a 5% increase from the district for the district's cost. The blended, and what I mean by blended is when you look at all of the tiers as a whole, it's about a 5.6% increase. And what we did do is there were different. You guys, I believe, were on a 3-tier structure before. So what we did is we broke those into 4, and so there are certain tiers that, especially the employee plus children, I believe went down about 4% because they're not being subsidized by, or they're no longer subsidizing the family cost. So does that make sense how that happened? Because they were paying, because it was the employee only, employee plus employee plus spouse, and then I believe it was the children and family were the same?
One dependent, so it's just
One dependent.
employee plus
Employee plus one.
Employee plus one, okay, and then the family. So the employee plus children, one child and the employee is less expensive, right, to insure than a whole family. So that's why the family rates went up a little bit when the employee plus children went down. Does that make sense? And then I put the tiers too, so you can see that I believe it was the most dramatic impact for the copay to add family. That was where it was a little bit more dramatic. But again, depending on which direction the district wants to go on, if we tweak up the $1,500 employee only plan and make that a little bit more expensive, then you can offset the dependent care. But then you just have to go back and think, okay, that's 270 that are on the employee only. Do we move their rates up in order to offset the other 20 people that are the dependents? And that's just a district decision at that point.
Tara, can I interrupt?
Yeah, absolutely.
Are you saying that the core plan that you're presenting here is similar to our value silver?
Is that your highest level? No.
No, that's our entrance level, and then the copay plan that you're presenting is the value gold.
So what I'm saying is the 1,500.
Right, well, we don't have any high deductible.
I'm sorry. Your 1,000 plan. So the $1,000 plan would be in price wise and with the deductible wise next to that 1,500. But it's going to be different as far as the plan design goes because they're not going to have a copay first. That would be one where if the district said, fine, we'll pay for the copay plan, it would be about a 15% increase from what the district is for the district's cost. Now, all of the employees would be very happy in that it would obviously really offset the amount that they're having to pay. But that's a big line item in the budget. I definitely understand that piece.
Okay, I have a couple of questions.
Yep.
Tara. As I'm coming back to something that Chuck was talking about, and the question that was asked about, that Lori asked, I guess, about the high deductible, or anything where we have the deductible at all. On your plan, does the deductible kick in just for the regular visits and things, or only for the hospital consults?
It depends what plan it is.
Which plan it is?
Yes.
Okay.
So
which plan would that affect?
So so let's say on the copay plan, let's say actually any of them, if you're going to go to the hospital, you're going to be meeting that. There's not going to be there's not going to be a copay for any of the hospital fees. So you're always going to have to hit the deductible on hospitals.
Going to the hospital.
Yes.
For emergency.
For emergency, yeah. For the emergency or anything major, right? If you go to the copay plan and you just want to go to the doctor or a specialist or urgent care, telehealth is free on that plan. If you go to that plan, then you don't have to meet that deductible before those copays kick in.
So the copays kick in right away?
Yes.
Okay.
But for all of our high deductible health plans, if you're on if you're on a medication that you're taking at a maintenance medication. Now, as soon as I say maintenance medication, people always just think medication, so I have to medication or the maintenance meds. So
High blood pressure.
Your metoprolol, your simvastatin, any of your statins for cholesterol, those types of things. If you're diabetic, a lot of the medicines for that, because we don't want you to stop taking your medications because that leads to more claims. The copays are going to kick in right away. But we have a list of those too, so that we can educate employees before you pick that plan, because you see that you're going to get $1,800 put into your HSA accounts. Let's make sure that we're checking your meds to make sure you're not paying $600 a month out of pocket first for a medication that you might be on. So, you know, we want to make sure that we're educating on the front end.
Okay, and then, Tara, so on this table, so the monthly medical premium, if I'm just looking at that column,
Okay.
the first column,
Yes.
tell me what that means.
That means it's the total amount that it's going to cost.
So
The
one
di-
employee
so if you
is
add
going to
con-
cost $934.
Not yes. So what that means is with your rates, in addition to what the employees will be responsible for, is what Kairos will collect for that plan. So
Wait a
you'll.
minute, wait a minute, back up. So in this, so let's just look at line 1.
Yep.
So the monthly medical premium is $934.
Correct.
Okay. If the district paid $934, what happens to the numbers across to the right?
So then that would mean that the monthly contribution from the district would read $934.
Right.
The employee cost would read 0,
Okay.
0, 0.
Okay, thank you. So, so what I'm getting at is this table shows what would happen if the district paid $818.
Correct.
On any of these plans.
Correct.
Okay, if we pay, you know, if our group paid, our trust paid $818, then the cost to the employees across.
Yes,
But
ma'am.
if the trust were to pick the numbers that are in column 1 under monthly medical premium, then that changes the numbers across.
So yes. So if yes.
Okay. Does that make sense to everybody? Does that answer the question everybody kind of asked?
No, so what you just said was the monthly premium is $934.
Yes.
So if the district pays that, then the employee has no cost.
Right.
Correct. Okay, so how does that work that if the premium is $934 and the district pays $818, why is the employee paying $865?
That's for the whole year.
No.
Oh,
Right,
that's
that
what
doesn't make
that
sense.
Monthly.
that was supposed. So what that was
It says monthly.
right.
Yeah.
So it was the
That means the whole year.
so it was annualized.
Yeah, it's annualized. I figured that out.
Yeah.
Well, then the next column's wrong also.
So
Yeah,
then
it's wrong also. Yeah.
we opened
It
the
just
wrong
means
one.
that would be what you'd pay over the whole year if you wanted that plan.
Okay, so
Yeah,
the
but
monthly
payroll
is
deduction
$964.
wouldn't be right either.
Exactly.
Yeah, so one of it, so that annualized on that first column set off
Yeah, it's
the
not
other
correct.
ones. Yeah. So I can even, if it, Kimberly, what I can even do is I can just fix it too on here and just email it back so that we can get it to the group. But, so that, so you're right. So that's annualized on the monthly costs, or it
What's
should
the
be
22
monthly.
periods then?
So the 22 periods, what they want to know is what's going to come out of my paycheck.
And that's presuming that there are 22 pays, and most of ours have 26.
Yes,
pay.
and John got me that
Most
today
of
last
us
week,
have
yeah.
26 pay, but, right, most people have 26 pay.
Thank you for
But
that.
we're still
Well,
in the period.
Yeah, I would.
Oh, the healthcare's paid out of
It's all gonna be done
22.
in sales tax before,
Yes.
before county.
It's, the math is still wrong. So, the 934 minus 818 is 116 times 12 is 1392. So the employee's cost would be,
We'd only be times 10.
No.
No, it's-
annualizing
It'd
it,
be
13.
times 12 and then
And
divided by 10.
Right.
and then divided by 20.
So,
It should be the 934, it
Minus
should
the
say
818.
equal, whatever that's out, so 934 minus the
is
818.
116.
Mm-hmm. And then what you're gonna do is, so that's the monthly.
Right.
So then if they wanted to annualize it, it would be the times 12.
Right, which is 1392.
Mm-hmm. And then it's divided by 22 for the 22 pays.
So essentially, the one, the
Because they
column
get
that says
paid.
monthly employee costs.
They
is
have their
equal.
insurance taken out
Correct.
over 22
Yeah, that's-
So-
that's
instead
what
of
columns were.
26.
This is true because you don't take it out of the third payroll. If we have months with 3 payrolls.
But in general, isn't it,
Comes
John,
out to
22
two.
doesn't even out all the way
And
to
they have to
22?
have it all paid before summer in case they.
You know, right now, we're at 22 because we pay it.
Oh.
The district pays.
60,
pays
it's,
Does that happen?
Like we paid up to 934.
I think you need to rework your table.
Yeah, I will. I'll just do. I can even do that right now. I can do that right now and send it over to Kimberly to send it out.
We can put it up.
Right. But can I ask this, Carolyn? For the group or for the 818, is that pretty solid as far as I know that you guys are working through budgets right now?
No, not for the high school district. It isn't.
We're not that far yet.
No.
as far as
We were waiting
determining
for
what
information.
your rates can be.
Yeah, we weren't that far yet. We were waiting to hear the information from you all.
Okay.
To kind of work on that.
Okay.
Because this doesn't include your dental vision or anything like that.
No.
No, and that's always that's going to be the employee portion of that. Yeah, so
Well,
any of the
the districts have paid it in the past, so that's
Oh.
why this trust will be deciding whether we're continuing to pay vision and.
Perfect.
and
How,
dental
do you
or
guys
not.
contribute the
Okay.
entire amount for dental and stuff? That's
We have
great.
been. We have been.
That's awesome.
In the second column where there's the number at the top 10, and then we have 57, 112, 269, what are those numbers?
Say that again. Oh, on like
Column
no,
two.
that's just where or that's just the current enrollment, and that's the assumed migration. So
Okay.
We currently have 10 in, and that was what I was asking. The core is comparable to our classic silver. The copay is comparable to our value gold. And then your high deductible 1,500 is our value silver. I'm trying to make the correlation.
Yeah.
No, it's going to be
What-
HDDP.
HDDP.
1,500.
We don't have that at all.
We don't have that. She's
No, we don't.
migrating 269 employees into our
which I don't think would
HP.
happen.
well, if the district, so here was my assumption on the migration piece on that. If the district is saying we fund the most that we can fund is 818, or we can only increase our contributions by 5%, whatever that number is, the employees are most likely going to have to go to that plan because they're not.
They're going to migrate to the plan that has no contribution on their part.
Yes.
Right. Okay.
So whether that's comparable as far as the actual, like, hey, I go to the doctor, so I want to hit my copay first. Those are going to be things that they might have to looking at the copay plan and saying, okay, is it worth having to pay up for that? Or if I pocket that, is it going to be, am I better off pocketing it and then using that toward my pocket or my out-of-pocket expenses?
Do we have a breakdown of employee ages? What is the average age of an employee?
Now I wish Michelle was here.
I mean, is it 25 or 55?
No, you guys have
Yeah, I would say 40.
you guys aren't a young district by any means.
I would say.
Sorry, I didn't mean that.
I couldn't resist.
We have some districts that are like, the average age might be like 38 or we consider that younger. Yeah. I don't think that you guys, because usually in my underwriting analysis, when the team sends that back to me, I can see all of that and they'll highlight that piece of it. So I wouldn't say that, but there was nothing in there that said, this is a little bit scary because of, the age demographic. They didn't say that at all either.
Okay.
But I don't have
I
the,
think we have really young and then mature,
yeah,
Right?
wiser.
I agree with that.
Vintage.
I resemble that remark.
the seasoned teacher.
Well, it would make a difference as to their age, as to whether they would migrate to that.
I continually hold out. I do not want to charge people for benefits.
I know it's hard.
I don't think that many would go for high deductible. Could I just ask a question?
Yeah.
Looking at your presumed numbers that would move from our current plan to your new plans, that 269, you're looking at close to 300. As one of those 300, and I go to the doctor once as a preventative, I would think that there's no way they're signing up for that high deductible plan, because that literally means I get no coverage aside from my preventative
And telehealth.
until I play. No,
So telehealth
you
is
said
more too.
only telehealth is for the copay.
So you get $0 for, well, I'm saying you have a copay. So for telehealth on the high deductible health plans, if there's a mental health parity act in there, so I have to make sure that I say this piece, but on the high deductible health plan on ours, it is $49.99 if you're calling in, so you don't hit that $1,500 or the $25 or the $5,000. So if they call in, as long as it's not for psychiatric services or any, for the typical, you call for a cold or an infection or a UTI, things of that nature, it's going to be that $49.99 before you're going to that
Every
$1,500.
call?
Every call. But if you're going to,
So then is Teladoc still on yours?
Teladoc
For
is,
every plan?
it's free on every plan. If you implement a high deductible health plan, it's $40.
But
on the
But
regular.
on a regular plan, it's zero.
so there's no other option, because that is mass majority of our employees that are on your presumed high deductible. So then, and I don't know your name, I'm sorry, Chuck. So you didn't do the presumptions of the carryover for your suggested plans for next year?
Yeah, no.
So then am I right to make the assumption that now close to 300 would be on your high deductible health plan?
Not necessarily. I'm looking at the Value Bronze, which is a PPO plan, which that one has a $2,000 deductible, but it has co-pays. So it has a $30 or a $40 copay and a $50 specialist. So
45 to 55.
yeah, 45 and 50. Okay. But the district might not move at all. They might just keep the same plans, and that's fine. But I'm just saying, if the district wants to save money and be able to pass it along, we're looking at other options. High deductible happens to be one of the options, but at the same time, we also have the Value Bronze, which is also a copay. And so I haven't made any assumptions yet.
Yeah, okay, thank you. It seems as though that there would be a different ground for those nearly 300 employees to land on, other than.
Well, I think one of the things you have to consider is that she's doing this presuming that the districts were going to pay only $818 for any of these plans.
Yeah.
So one of the things this trust can decide is, no, we want to offer, I'm going to just use this as an example, okay? So that maybe the trust were to decide we're going to offer for employee's choice, core, copay, and HDHP 1500, but the district will pay $896. So if you look at that, that is the district paying the amount of $896.
Then I would assume.
And then the rest of it shifts a little bit. So that's raised that. It's made that more like what you were talking about. And those are the options that this group has. And they have them with what Chuck's presented, and I'm sure they have them with what the next one that's going to be presented as well.
Okay.
And I have to tell you that part of the reason you got this table looking this way is Tara called me yesterday and she said, how do you want me to present this information?
I wasn't sure how the direction of the, the district.
And I didn't know if I had an answer.
Yeah,
So,
absolutely.
Well, we were developing hypotheticals relative to contributing to vision and or dental, and we cover the health, and then having options that the board can review. We still have another to review relative to what you did for us.
So Todd and I discussed it last night, and then we contacted her and I said, okay, just go with, my best guess based on that, because I figured at least it gave you all numbers to look at and to consider. It's just a different way of looking at, it's just a different way of looking at all the data in terms of if the district had picked a number out of the air, If the district picked $850, I wouldn't want us to pick that necessarily, but if we picked $850, then she would have put that in the middle column and then arranged everything around that. So it's just a different way of presenting what Chuck presented.
And all of these numbers do not include dental and vision, which is another 5410.
But if we were going to pay all of it, and part of the discussion, if you remember from the previous time, is that you all may want to consider particularly the vision, that discussion about vision relative to things that Michelle learned about other ways that our folks can get vision care that costs nothing.
Vision is only $6.
Right.
Dental is $47. Let's get rid of dental.
No.
All right.
Well, no, the other
answer. Right answer.
The other thing
why do we want to get rid of either one of them for $6?
And I'm not
No,
suggesting
we
you
were
do that.
suggesting getting rid of it. We were suggesting discussing the cost and the sharing of the cost.
Well, the other thing too, a lot of districts will do is they'll say, hey, we're going to contribute dollars a year, or a month. However, if you decide you want to spend it on dental, spend it on dental. If you want to spend it on all medical, you can spend it on all medical. That way, you're not taking it away, but you're also giving them that choice if they want to buy up or if they want to, put it into their HSAs. So it's a lot of flexibility on that part as well, that you can give the flexibility to employees who, some that want the dental and then some that are like, I can go do without.
But then that goes into preventative, because you have bad dental health, then it goes in, you have gingivitis or periodontal disease, it goes into your heart, and then we got the medical costs going up. So What do we want to do with the aging population of our teachers?
Easy.
All us old people.
I'm really 20, the job has aged my
That's a lie. I know my age.
Sharon.
Me too. The board has aged me.
Dr. Stewart, were you gonna ask the same 3 questions?
I am going to
Okay.
ask the same 3 questions.
Thank
So, Tara, is there any kind of a price break for dual spouse?
No, for the family, or so it would be for each of the,
Both spouses work for
the school district, they would both, if they were both on employee only, they would both pay, or if you funded it, they both pay 0. If they were on the family, they're not gonna get a price break for coming back on. It's just because we can't cover their claims that way with that kind of price break with the premiums.
Okay, and then, is this a 1-year plan or a
1
multi-year?
year, 1 year lock-in.
1 year, okay. And then, John's question,
Well, that was what I kind of sorted out, I think.
the hospital specialist, so you would do the same thing Chuck said, is that
We get
Congress would go to
aggressive.
bat for our employees for those.
We write scathing letters.
outlandish things.
Yeah.
Okay.
Yep.
And what insurance company are we working through? Blue Cross?
So it would be Kairos that would be insuring you, but the network would be the Blue Cross Blue Shield expansive PPO. And then that also has the Blue Card access, which means if y'all did go to Nevada or to the Las Vegas hospital, as long as you're accessing a Blue Cross Blue Shield either provider or facility, that's going to be considered in network for your employees.
Anywhere in the U.S.?
Yes. So like if you have a dependent that goes to Indiana University, they can use that as well, and they access the Blue Cross Blue Shield network, whether it's Anthem or Wellmark or Blue Cross, whoever it is.
Chuck, did you want to speak to that?
Ours is the same way. I mean, it's similar.
Nationwide.
Ours is nationwide, yeah, absolutely. So,
And you're Aetna, right?
yes.
And is your Blue Cross Blue Shield, can you access the Mayo Clinic?
Yes, ma'am.
Ashley?
Yes.
Trying to keep it even here.
No, it's good.
Trying
Nope,
to keep it
he
even.
doesn't.
Sorry, you just have to hand out paperwork.
Totally, yeah.
Okay, thank you.
Yeah, no problem, guys. Thank you.
We have what you sent us.
We have some of what you sent us, but letter access of that.
So let me take a brief moment to introduce Stephanie Moore. Stephanie Moore is the account manager for Aaron Collins and Associates. Just to give the trustees a quick update, the city of Kingman, Bullhead, and Havasu have a trust that they formed back in 2012. And just recently, they allowed school districts to join. Last week, the school district of Havasu joined the trust. We got this information a week ago from Toby Cotter, our city manager. So I reached out to Stephanie yesterday, and she was very quick in getting back to us last night and today. And she's here within less than 24 hours to present. So Stephanie, I want to thank you for coming, and the floor is yours.
Thank you, John. Madam Chair, trustees, and superintendents and staff, and thank you very much for the last-minute invitation to present to you today. I just want to start out with a little bit about ECA and who we are. So ECA was formed here in Mojave County in a kitchen table in Kingman in 1992 by Aaron Collins. Some of the core principles that we have are really putting the control of the trust in the hands of the trustees and the employers as part of the trust. Sticking to that statutory compliance, so making sure that you're following open meeting laws and making sure that all of your federal guidelines and everything are being followed to the T so that the trust is protected from any challenges. One of the areas that we really focus on is in financial strength and transparency. That's one of the biggest problems there are out there with insurance, and is that when you're insured, your insurance company comes to you and they say, we have a 20% increase, and you say, well, that's too high, and they say, well, how about 10%?
That's how it is.
Magically, some of those things can disappear. Now, it's not so much like that with a self-funded trust like yourselves. The numbers are there. You're paying the claims directly. But there's lots of ways for money to go other places that when it's not being watched carefully. We pride ourselves on full transparency, and we require that with all of our vendors as well. So we account for every penny in the trust every day. We like to keep our trustees educated, fully informed, and empowered to make decisions on behalf of the members that are in the trust. And then just keeping the trust and the vendors aligned so that the goals are clear of where the trust wants to go. So because we operate by those core principles, ECA is the largest provider when measured by the number of pooled trusts that we manage in the state of Arizona. So we clearly don't have we don't represent the most employees, but we feel that pooling entities by not only geography, but by similar challenges and goals is a better way to pool groups. So the challenges that you face in rural Mojave County are not the same challenges that cities, towns, and school districts face that are in Metro Phoenix. So a very little bit about the staff. So Aaron, as a master's in public administration, he's been in HR risk management through city, county, and community college representation. He has over 30 years experience with employee benefits, handling both single and multi-employer trusts. I am Stephanie Moore, as Todd mentioned, and my experience is both in HR, city government, and standalone insurance. I have over 22 years experience in insurance and employee benefits. Also, the last 5 years with ECA, managing single entity self-funded trust and 2 multi-employer pooled trusts. So overall, our whole company is very highly experienced in public sector plans, and we really strive to be an extension of the staff of the trust. So each individual entity, the folks that work in your HR benefits or in your payroll departments, we really try to coordinate directly with those people and assist them when there are claims issues or in any other issue that comes up. So some of our clients locally, obviously we mentioned Northwest Arizona Employee Benefit Trust, which includes Lake Havasu City, Bullhead City, and the city of Kingman. And then Todd mentioned Lake Havasu Unified School District, which is joining NAABT, but hired ECA a couple years ago to help them get out from underneath kind of a bad financial situation with the clinic they had put in and some of the other things that were going on in their trust that honestly they didn't even really know that were going on. Yeah. And so Jamie Schulenberg in our office worked with that trust, and she helped bring them to a place where they're finally ready to say we're to be part of a pool. And they applied for and were accepted by NAABT effective July 1st. We also represent Mojave County, Kingman Academy of Learning, the town of Parker, Golden Valley Fire District, La Paz County, and Fort Mojave Indian Tribe here locally. So statewide, we also operate Arizona Local Government Employee Benefit Trust, which has kind of the smaller counties in Arizona, and Rural Arizona Health Group Trust, which has all the little burgs and towns all over the place that can't really stand alone on a self-funded plan, but when they join together, there's 19 entities that came together to create that pool. Cochise Combined Trust is one of mine. That's Cochise College and Cochise County. Arizona Metropolitan Trust is our Phoenix Metro Trust. And Northern Arizona Council of Governments and the City of Sierra Vista is another one of my clients. They're a standalone self-funded trust. And then Central Arizona College, which was self-insured, then went fully insured, and now we are moving them into Cochise Combined Trust effective July 1st. We'll be changing the name, of course, to welcome them. And but again, one of those things where they got some things straightened out and now they're ready to go back and join a pool. So how we see some of these pools is, different entities, different types of employees, but you all have the same issues. So every entity is trying to recruit and retain great employees. You want to have some flexibility in your benefit design. Lots of times we have discussions in our renewal meetings about might be important for one entity to keep the copay low, and another one it's important to raise the emergency room copay, or keep some cost, or raise the number of visits. And it's amazing how a group of people can get together and really listen to each other, what's important, and come to consensus by the end of the day and have a budget, which is pretty much how we operate our pool trust. Obviously, the legal compliance and financial considerations, stability is incredibly important to these trusts. I can tell you that all of our pooled trusts, if you take them over time since their inception, every single one of them averages under 4% annually for increases. Most of them are under 3%, but all of them are under 4% average since inception, and some of them, like my Cochise Combined Trust, was started in 2002, and the Arizona local government was in 1995. So long time to maintain those kinds of lows. Now some years are rate passes and some years are higher, but average overall less than 4%. All of our trusts operate on one trustee at the table with a vote. So this group is sitting a little bit differently, and you would have, if you were to look at joining NAABT, you would have the option of either coming in individually, so both your superintendents would have a vote, or you could come in together, maintain the board, and you would have one vote at the table. So, in looking last minute, brainstorming since yesterday at 4 or something, I kind of have a twofold proposal for you. One is to come in in a broker role and help you to determine what's going to be the best option for you, doing an end-to-end review of your entire trust. Looking at all your claims experience, looking at the rate adequacy to see if you're funding at a level that's going to build that surplus for you to cover for those difficult times when you have the large claims, like the $1.5 million claim you're experiencing now. Looking at your total cash versus your incurred but not paid liability that you're running each year. Looking at the costs, your fixed costs and your variable costs. And then looking at it, I don't know, if you have retirees, if you provide retiree coverage or not, looking at those liabilities as your retiree coverage goes on. So making sure that you're thinking through how that plays out financially. Looking at all your financial reporting and then setting up new reporting for you so that you're getting a monthly report letting you know where every penny is that's coming into the trust. Looking at all of your contracts. Are all the contracts held in the name of the trust? How are you getting the procurement? Is it by RFP? And who's making the decisions on who the vendors are that the trust is working with? Looking at the costs, looking at the terms, renewal, and how the contracts are reviewed. We write our own contracts, making sure that the interests of the trusts are primary in every contract. That we make the vendors agree to the contracts that we hold on behalf of the trust. And then looking at all of your structure of your trust meetings, your agendas, minutes. You had the discussion earlier, but making sure that they're available to the public, that you're operating in the sunshine, so that the public knows what's going on, and that you're never in a position where somebody can say, had I known that this was going on, I would have been there to say something. So then after the end-to-end review, just ongoing consulting, looking at the district's scope as well as ECA's scope, brokerage, consulting, the meetings, doing bids or RFPs for the group, and then special studies reports, and then supervising the vendors. So that's kind of the broker piece of it, and that's not really looking at which group you decide to insure through, but you need somebody looking out for the very big picture. So I kind of covered all that stuff. So with regard to the vendors, I mentioned contracts written in the name of the trust, making sure that the scope of services is defined. So exactly what is that vendor going to do for you, and then somebody to say you're not doing what's in the scope of services. So we need you to step up and do that. Making sure that the compensation is correct, that what they're getting is what the trust agreed to pay them, and there's no commissions coming in the back door. There's no other fees going out. There's no PBM RX rebates going to your broker or your consultant, or because I'm telling you, I'm sure it's shell game. So you have to be watching every dollar, and the contracts are what really keeps everybody in line. To make sure that they agree to accept the fee as their total compensation. So at least if you find out later that somebody's getting something, you have some recourse. And then measuring performance of everyone. Most of these contracts have performance guarantees in them, but how many times do you go back and say your customer service performance guarantee is X, and according to your reports, you're not. We want a credit for that time. So we do all that. And then other services that we provide, that we do outsource, but we have great sources for them, are legal services. So independent counsel looking at things to say, very experienced employment and benefits legal services to say, this is good, this is not so good. I'm working through right now all of these things with Lake Havasu Schools joining that trust, and the attorney's just getting things back. Actuarial services. It's 6 of one, half a dozen of another, where your actuary is, but I like the idea of an actuary that has nothing to do with the plan. Having an outside person who you give the plan design to, you give them the claims information, and they generate based on the history and all the stuff that actuaries do in dark rooms with no windows, they determine what rate is required to sustain the benefit plan. The way we do it is when we get ready for our renewal, we send all that information to the actuary. We also send them everything we're thinking of that we might want to change for the future. So when we get together for our renewal meeting, we can plug in anything that you think you might want to change, plan design wise, and spit it out in a minute. And by the time the meeting is over, you have a budget. So it's a little bit different way of doing it, but it works really well. So then, the other side of the opportunity is to look at applying to join Northwest Arizona Employee Benefit Trust. So Northwest Arizona Employee Benefit Trust, as I said earlier, is a multi-employer trust formed in July 1st, 2012, and includes Bullhead, Kingman, and Havasu, and again, for the 90th time, Lake Havasu Schools is joining, effective July 1st. So it's a much more simple operation than most of the plans that you've heard about today. They have two plans. One is an EPO, or exclusive provider organization, which means it only has in-network coverage. The other is a high deductible health plan, which has that out-of-network component if you wanted to go to a provider that's not an in-network provider. Both plans utilize Blue Cross Blue Shield of Arizona and Blue Card nationally. So that's the national network is available on these plans. Mayo is specifically excluded except for transplants and anything that requires the blue distinction or a center of excellence for that type of facility. And of course, emergencies. So if you find yourself in the parking lot having an emergency at Mayo, it'll be covered. The reason that our trusts do not include Mayo, and of course this is a trustee decision, we look at it every year, but Mayo causes your rates to go up. Right now, Blue Cross Blue Shield has what they consider a very good discount with Mayo Clinic. But if you have a $100,000 surgery done at Banner, that same surgery done at Mayo will be $500,000. So 60% off of $100,000 or 60% off of $500,000 is still more money. Okay, and that's the problem, is that they start here and they give you a good discount, but you can never get to the same place that you're getting. Now, when you have to go to some place for a heart transplant that does them routinely, and you get the best care, and you get in and out, and you get well faster, that's worth paying those prices for, and that's why the plans allow those ones, but not a knee replacement. NABT also offers one dental plan, one vision plan, and they bundle those, so it's dental and vision. Life and accidental death and dismemberment, telemedicine through Teladoc, EAP through EAP Preferred, and then we have a really robust wellness program that we have a wellness consultant from ECA that conducts that program. So a few of the questions that came up earlier about Teladoc and how that's covered. On the EPO plan, the first 4 visits are free per participant per year, and then it's a $10 copay after that. On a high deductible health plan, you have to pay the $49 fee until you hit your deductible, and the deductible on the high deductible plan is $1,400 for an individual, $2,800 for a family, and then the plan covers it at 100% after that.
Did you say there was no out-of-network coverage on the PPO side?
On the EPO, yeah. So if you're traveling and you have an emergency, it's going to be covered because emergencies are covered everywhere. And honestly, with Blue Card, you really don't. We haven't had anybody come up with a reason that they can't go to. Almost everybody takes Blue Cross Blue Shield. You can almost find in fact, Blue Cross Blue Shield says in every zip code there's.
But you have the rare specialists that take nothing. So what do you do in those instances?
So there's always opportunities for that. You can get a benefit exception to go someplace. If there's a sole provider type situation, it goes through. In those cases, sometimes it will just come through me, and as a trust administrator, I'll approve it based on the case management reports. If it has to go to trustees, then it goes to trustees, and trustees vote on whether to cover it or not.
Okay.
But if it's a sole provider thing, it's usually going to be covered.
Okay.
The next slide just really talks about our rate increases. So for the high deductible health plan, 3.95% since inception, and the EPO at 3.31%. On the high deductible health plan, they actually reduced the maximum out of pocket last year. So they reduced it from $4,000 for an individual, $8,000 to a family, to $3,000 for an individual, $6,000 for a family. And then this year they had a 2% increase, and they actually made some improvements to the plan. So they upped behavioral health to 45 visits, and they added some additional benefits, 100% coverage for all on-site screenings, and we have a slew of them. For the EPO plan, they didn't really make any benefit changes, in the prior year, in the current year, 1920, they actually upped the funding rate by 3%. That wasn't required because they wanted to boost the surplus a little bit, to give themselves a little bit more space between cash and incurred but not paid. So this year also on the EPO there was a 2% increase. So I alluded earlier to the governance and membership a little bit for NABT, for the trust board, one trustee from each entity, and it's the city manager or CEO, or what we would consider, the comparable would be the superintendent, and then one alternate trustee to sit in the event that the trustee is not available. So it could be your business manager, it could be your HR manager, whoever you feel is the best person, and that's an entity decision, that's not a trust decision. The way the pool works is it's 3 years in, 3 years out. So once you come in, you're in for 3 years. If you decide to leave, you are still responsible for your contributions through the end of the time period. So nobody does that. If you do decide to leave at the end of your 3-year period, you can't come back in for 3 years. Okay, so how NABT started was they started out with 3 years, and then they now continue to do 5-year renewals because they love working together, they found consensus, they love not competing with each other on their benefit plans. All the 3 cities have the same benefits, so that kind of takes that right out of the picture when you're looking at jobs, right? They're all the same. There is no buy-in to join the trust. We determine or follow your surplus deficit every month, and we provide that reporting. We provide it on an annual basis, but we can provide it monthly if you need to, if you want to see, how your share of the surplus is coming. We do all our meetings subject to the Arizona meeting law, and then we do all the contracts and everything through a competitive bidding process. And ECA handles all the RFPs for everything. And then again, all the contracts are held in the name of NABT. On the next one, it kind of has the organizational structure of the trust. So the NABT beneficiaries, we consider them the end result, the most important part of the whole equation. And then the trustees. And then there's an independent audit done each year on the trust, and then the attorney. So those folks are there to support the trustees. And then ACA is underneath that to administer the trust and manage the wellness. And then everybody else in the box are people that we, that this trust works with. So everything is unbundled with NABT, so nothing is together. We have individual contracts with anything. So if we don't like the pharmacy benefit manager, we replace the pharmacy benefit manager, and everything else stays the same. So Ameriben is the third-party administrator. Sun Life handles the reinsurance. Chiron is the actuary. American Health Group does the utilization management, so pre-certification and case management. Teladoc does the telemedicine. The Standard does life, AD&D, and voluntary life. Blue Cross Blue Shield of Arizona is the network, and Blue Card. Emeritus does the dental and vision. These are both self-funded plans, so none of it is fully insured. It's all self-funded. EAP Preferred provides the employee assistance program. Navitus is the pharmacy benefit manager, and FSA, dependent care, and health savings account, we help administer those, but they're different companies, and that's kind of an entity decision. So underwriting guidelines for NABT, the requirements are that the rate structure that you would be offered are based on the actuary's recommendation. So how that would work is once I can get the claims information and some of the stuff that Chuck was able to provide for me today will help a lot. I'll be able to submit that information along with your large case information to the actuary, and also your current plans. So the actuary will look at your current benefits in comparison to the NABT benefits and determine if your plans are richer or if the NABT plan is richer, and they'll adjust for that, and then take into account that claims history and generate rates based on that for your specific group. So now, Lake Havasu schools came in about 35% higher than the regular rates for NABT, and so NABT voted to allow them to join on a separate rate structure. So that is also possible depending on your rates. And I didn't have them till just now, so I'll be able to get those to the actuary tomorrow morning, and we'll get some rates generated for you, and I'll be able to bring those back to you and send them to
So Havasu's schools rates were 35% more than, say, Lake Havasu City's rates?
Their funding rates.
Funding rates.
So just the amount that's required to pay the claims, basically the claims portion of it. Yeah, 35% higher, but still less than what they're paying now.
Okay.
So a little bit different. Part of the NABT requirements are 80% of the employee-only coverage based on the lowest price plan and 25% of the dependent coverage based on the lowest price plan. Now, I know currently that you are not contributing to dependent coverage, but if the numbers are right, you may find that you're able to make that shift a little bit and do that funding because Lake Havasu Schools was able to do it. And it also helps you retain and hire families when you're offering a little bit of dependent coverage to your employees. It makes a huge difference. The way NABT works is all the benefits must be taken. So you must take, you don't have to offer both plans, but you must take medical, RX, dental, vision, life, EAP, and wellness. So it's all bundled together, but by different vendors. So the advantages are greater rate stability, and then increasing power, negotiating power due to the pooling, which you already experienced through ASBATE and would also have through Kairos. Because as you get bigger, risk gets spread across more people, and you can make better claims predictability, but literally what happens is you have high claims for a couple of years, and these folks have low claims, and then you have great claims and they have high claims, and you balance each other out. So overall, the trend is across. These plans that are built for this area are built for this area. They're built for the average pay that people have, the affordability of the plans as far as co-pays and maximum out-of-pockets and co-insurance levels are designed for the people who live in Mojave County. And the trustees are selected by the member entities. So the people who are sitting at the table are every single entity, a representative from every single entity that is part of that trust. There is a huge emphasis on wellness because that is the beginning of breaking the cycle of medical claims. So if you can help people stay well or help those that aren't well be as healthy as they can be, then you're reducing claims in the future. And so this trust is very high on making sure that wellness is a big part, and that's preventive screenings, activity, nutrition, and all kinds of different programs to make sure that people are staying as healthy as they can be. I mentioned there's no financial buy-in, so if you're accepted, if you do apply and you're accepted, there's no fee to join. We just work everything through. The contribution strategy is individual to the entity, but we help you work through that to determine how to best split that up between the employer and the member. But again, that is completely up to the entity. Obviously, the opportunity to grow a surplus is a definite advantage right now. NABT has, for what I would consider a fairly small pool, they have about $4 million in surplus right now. So their goal is not to maximize their surplus. Their goal is to hold a reasonable surplus and allow the entity to hold the money that they need to operate instead of growing a massive surplus that in all likelihood that massive amount would never be needed. So what are the disadvantages of being in a pool? Obviously the need for consensus. You're sitting around a table making decisions, and the way that we design it, we do not have plans that are set. There is nothing structured going into this. This is the A plan, this is the B plan, this is the C plan. These plans are designed by the trustees with ACA consulting at a meeting, surrounded by your vendors. So if you decide at the last minute, what if we did this? That vendor is going to provide that information if it's a medical, dental, vision, pharmacy, and the actuary sitting in the room, crunching the numbers, and able to give you those numbers while you're sitting there and see how they affect your budget to determine how you as a group want to design your plan for your employees. The other side, the other disadvantage is exposure to deficits. If you have bad year after bad year after bad year after bad year and your surplus is gone and you start moving into a deficit position, then the trust document states everybody's got to get their checkbooks out. So that's obviously a fear. It's never happened with any of our trusts and probably hasn't happened for any of these guys either, because with good management, you're looking forward all the time to say, obviously rates are a factor. If you're having large claims, you're going to see an increase.
And what if you have your rates drop considerably?
Well, so what we recommend is and this happens, if you might get a negative renewal, right? We recommend a rate pass rather than dropping rates. So the rates that you utilize don't change, and you're building surplus during that time.
Okay.
But there's plenty of years where our groups walk out of there with a 0.
Okay.
So, to sum it all up, till I'm able to give you some numbers, opportunity is we understand and live in your community. I specifically live right here in this community in Bullhead. We already represent the other public and private employers in your area. So we know the challenges and the costs associated with the rural coverage and being right next to Nevada. We get that, and California, but primarily Nevada. If you have a traumatic injury, you're going to Vegas, you're not going to Phoenix. So having that knowledge and working with those groups is, and knowing how it works, gives us an upper hand in that area. We are fully transparent, so when we tell you this is the fee we're making, that's the fee we're making. We work on a fee, we do not accept commissions, and that's how we operate. And then we're right here. Our office is in Kingman. As I said, I live here. My group benefit specialist lives here in Bullhead also. And so we're available to meet with you in person whenever you need help with open enrollment meetings, as I'm sure these folks do too. But we're definitely living here in this community. So, these are the values that were important to Bullhead City, Lake Havasu City, and the City of Kingman when they set up the trust. And frankly, we think these are probably the values that are important to you too. So hopefully, when we are able to give you some rates, you'll give them some consideration.
Thank you.
Thank you.
Any questions anyone has? Lance?
Do you want me to answer your questions? Oh, yes, sir.
I have both a question and a comment. First, the comment, Mrs. Frampton, I think this is just my guess, and please correct me if I'm wrong. I think one of the differences that you see between Havasu Unified and the city of Havasu, price difference, was that Havasu Unified was on their path toward the self-insurance plan that that a previous broker had suggested we go to, and their plan imploded. And so that's probably why.
They were underfunded, yeah.
So I think that's probably why their initial cost might be a little higher. But my question has to do with the EPO. I'm real familiar with PPOs and HMOs, and it sounds like the EPO is sort of a hybrid between the two. The HMO, which you don't have, obviously has real limitations, but it sounds like the EPO is going to have more practitioner limitations than a PPO does. How does that work in this area?
So the only difference between a PPO and an EPO is that a PPO plan has an out-of-network component. So if you are living in this community and you cannot find a Blue Cross Blue Shield provider facility, and you have to go out of network on the EPO, there's not going to be any coverage for that unless it's an emergency. The reality is, it's really not going to happen. Generally, and I'm saying like, I don't want to make any guarantees, but like 99% of everybody here that contracts with anybody contracts with Blue Cross Blue Shield. So if they're an anesthesiologist or an assistant surgeon or somebody that doesn't contract with anybody, they don't contract with anybody. So that's going to be the same situation for any network.
May I ask a quick follow-up question? We have got more than a handful of employees who live down in the valley, and so CRMC may be closer to them than Valley View or Warrency, and as well as some of the physicians and some of the clinics down there. Will this cover will there be any limitations on them if they have to go into needs, either for any primary care or any other care that otherwise they would get on this side of the river?
If it's Blue Cross Blue Shield,
They're okay?
they're good. Or if it's an emergency.
No.
How do you handle those claims that they go into the hospital or whatever, and there's different out-of-network providers that they have no, which you'll get a bill for, say, X-ray or something like that, reality, or how does that work?
So traditionally how it works is that the plan will pay the in-network pricing or reasonable and customary, and that member could get balance bill. And then the trust jumps in, either we jump in or the third-party administrator jumps in to discuss it with that provider. Blue Cross Blue Shield has a kind of a new way that they're doing things where they have the ability now, or they are starting to go out and do those negotiations, and they negotiate on the behalf of the trust and the member. So they're getting the provider or the facility to accept the in-network or reasonable and customary, and getting the provider to write off, basically eliminate the balance billing so that the member won't get the charges for the balance. But they're doing it all at the same time instead of negotiating on behalf of the trust or the insurance and then dealing with the employee side at a later date. So they're kind of doing it all at the same time now. Yep.
So our local hospitals are putting people on life flights on a regular basis when they show up to an emergency room due to the fact that there is not a doctor available at the time. So what would occur in this particular plan as far as being helicoptered out?
It'd be covered like any other ambulance ride.
Like an emergency.
Okay,
I
so
mean,
we
we'll go
wouldn't
on
need,
river.
so we don't buy the additional helicopter plan.
So the helicopter plan is only for the member, doesn't do anything for the trust. So, I mean, so if generally, if you were to be airlifted somewhere, you're gonna hit your deductible and your max out of pocket. So you're either gonna pay your max out of pocket to the air ambulance or to the hospital, and the trust is gonna pay the balance.
So now, how will that affect the district, since how a basic helicopter to the nearest hospital is?
They don't accept Blue Cross Blue Shield. They don't accept any insurance.
So Blue Cross Blue Shield has actually been negotiating with many of the air ambulance companies, and they are actually starting to make a little bit of headway. But I will tell you what we have found, and I'm sure Kairos and Asbate have found the same thing, is that most of them accept what the plan pays, and they do not balance bill the member.
Oh, yes they do.
Well, anything.
They hound you like a dog. $9 grand right here, paid it. Yeah, they hound you like a dog for the money.
You're
But-
probably on a fully insured plan.
Yeah.
Yeah.
Yeah. So, but I'm telling you, they offer that really cheap helicopter insurance here through our chamber. It's like $25. I have both. Now we have 2 helicopter companies.
Not anymore?
No.
Do we?
Air Methods. I'm sorry,
Oh, yeah, is it
Yeah,
gone?
they-
My understanding is that Air Methods, which bought CareFlight, had the plan which we were paying for as a district benefit, and Air Methods is dropping that plan.
Oh, they sent me a renewal,
But-
like by email, and I renewed.
Okay, the classic is continuing theirs.
Mm.
That was my understanding, but I can double.
Somebody sent me a renewal by email, and I was like,
can
oh
you
yes,
find
I
out,
want that.
because they send, Air Methods sends the renewal,
Yeah.
and I pay the $15 for my kids to be on it.
Yeah.
So I would,
Huh? Yeah, Air Methods just sent a buddy of mine a refund check for the balance of his,
Oh.
what he had paid, saying that his plan was discontinued. So that would be
Great.
useful on her.
So we need
So I don't
to
know
know.
if the district.
Yeah, I
Let
really liked
everybody
that
know.
insurance after I had to pay
Yeah.
$9,000.
I mean, that's a individual choice.
Yeah.
Whether you buy that insurance or not, but if you're being airlifted and you're going to an emergency room in Las Vegas or anywhere, and you're going from there to be admitted or into ICU, the cost of your ambulance ride, your cost sharing is really irrelevant because you're gonna pay your deductible and max out of pocket. It's just who are you gonna pay it to, right? You're pay it, and if you've already met it, then it's not gonna have any effect on you. So it really is just one of those things where, and in most cases, the trust is gonna pay whatever it is, 30,000, 40,000, 60,000. I've seen them 88,000. So that's just the cost of transporting.
Just if you buy your own insurance, that's just not true, right?
Well, there's a lot. When you're fully
That's
insured,
something
they have complete control over it.
Yeah.
You don't have the benefit of a third-party administrator negotiating on your behalf, or a consultant or a broker negotiating on your behalf. They'll just say, you know what, we'll get it from you next year.
Yeah.
Right?
Yeah.
So Stephanie, you've answered two of the questions that I
Okay.
was asking earlier, so I'll come back to that. Okay, so is there any kind of a price break for dual spouses?
So the way the plan is set up, no. However, contribution strategy is, again, up to the entity. So as long as the trust is getting the amount of money needed to fund the couple, how you structure it from your end is up to you.
Okay, and then the other one is, I've already gotten an answer.
Operates on an annual basis,
All my
1 year
questions
term.
got answered.
Yeah.
Thank you.
Thank you very much.
Thank you.
What's our time limit? So you have the bid like tomorrow?
Well, I'm gonna try to get you some numbers before the end of the week.
That means we have to meet again, people,
I don't know.
next week.
Next week is spring break.
What happened?
What?
What happened? They're on spring break.
Just
Well, you wouldn't have employees here for a meeting if you
Yeah.
went next week.
I don't
And
wanna
that's
meet
probably
without,
important.
they have too many good questions.
That's right, they do,
I don't wanna meet without them.
exactly.
Because we have the numbers next week doesn't mean we have to meet
Right.
next week. We can
Right.
hold off for another week, give us a chance to survey them, and understand them, maybe call everyone, ask questions, and I know Tara's reworking her numbers,
Yeah, I already did.
so we get a better look at those as well.
Do you guys have to have board approval by a certain date, or?
We're looking, trying to meet the open enrollment date, and we're pushing out contracts in March and April. So
Okay.
we're trying to get this all wrapped up before then. So by April
Yeah,
29th.
it all has to be done before we issue contracts.
Right.
Somewhere around.
What, you
Yeah.
didn't say February 23rd?
But I'm not ever a fan of employee contribution, so I hold firm on my place on that. As long as I've ever been on this board, I never voted for an employee contribution. It's my history. So we don't pay them enough for contribution or for a huge deductible, so just kind of where I've always stood, but we are having funding issues, so.
Keep fighting.
What?
Keep fighting. We
Oh, I do.
appreciate it.
I always do, as you know.
There are some that would benefit from a little bit of payment by employee, so they'd stop going to the emergency room.
Well,
If you pay in, you're more aware.
yeah, but we can
What
just
you're
say we
getting.
want a higher emergency
I
room
didn't say
copay.
charge them an arm and leg.
It's called skin in the game.
I have a question about the emergency room. So let's say you go to the emergency room here in Bullhead.
Say we want a higher
Okay, you go to
emergency
Warm
room
C.
copay.
Warm C can handle a splinter, and you have 5. So they send you to Vegas, to Sunrise, who then puts you in the emergency room. That's 2 emergency room visits?
Yep. Yes, ma'am, it is. But the problem at Bullhead City or at Wormsea or at Valley View is if they don't have a physician who will take the call, because neither one of these hospitals wants to pay the call for the physician to carry the beeper, then they can't page anyone to come to the hospital because they're too cheap to pay the beeper fee to carry the beeper to be on call. Then they would rather fly them to Las Vegas. And that's how that rolls. So they might perfectly have a physician who's here that could take care of you, but he's not on call, or he won't answer his call. And that's why he can't come take care of you.
That's what really happened to Gina, is he wasn't in call, he just wasn't there. I'm joking.
Yeah, no, but sometimes that's what happens. Or they're out of town, the one person who takes the call, or it's their call, or whatever, I mean. It's kind of interesting.
Extra penny so that they can buy pagers?
No, they have it. It's just that most of the physicians demand to be paid to be on call, which is a normal thing in every hospital in America. But in Bullhead City, they don't want to pay them to carry a pager. It happens in every hospital, everywhere. In Phoenix, do you think a physician is on call with a pager without getting paid? No, no ma'am. He's paid. But here, they don't want to pay you to carry a pager. You hardly have anybody in town that doesn't get paid to be on call.
Stephanie, Mayo is no on your plan?
Yeah.
Well,
Tara?
not all.
Yes, it is.
Yeah, it's all
transplants.
other than
It's all no.
transplants or
Other than
emergencies or.
Tara?
Yes.
Mayo is yes?
Yes.
Thank you.
But that's why you get flown out a lot.
Oh, I know.
Sometimes, I mean, we have more ortho than ever now, but
But we
it's
just-
really a riot. I had a friend at the ER here,
Yeah.
and she was going to get flown out. And I said, call Valley View and see if they have ortho on call. And they did. I said,
they were gonna live
walk
their
yourself out the door and go drive to the other ER. There's an ortho on call. You don't want to get flown to Vegas. So she did just that. Walked out, went down there, had ortho on call, and somebody saw her at the other ER. I'm like, it's that simple sometimes, but most people don't know it.
Those ER costs, it's not necessarily that person going that many times, it's they've been transferred that many times.
Yeah.
You know what I'm saying?
Sure, okay, right.
So, that's just a different way to look at
And
it.
then when they get back here, because I've been through it, there's an issue, and they tell them, you go to the ER. You go from here to there, and then back to here. It's not-
And then they send you back to Vegas because, well, this doctor in Vegas dealt with you, and we're not gonna touch it.
Yeah.
When do dependents age out?
26. Dependents age out of our plan at
Yes.
26. Yeah.
It's getting
Our plan, they age out at 26.
We're getting close to that.
But that doesn't mean I might not see another one as well.
I know, that's what I mean.
Can we get,
Years.
with the,
What?
trust,
Yes.
Ms. Aaron, okay, would you, when you negotiate the contracts for the districts, do you have a list of the doctors and the providers that are gonna be in that plan or
Teacher
available
meeting
to us
date.
via the trust?
So it's Blue Cross Blue Shield, so it's their provider network. So you can look it up online
So
or.
just go online and look at Blue Cross Blue
And
Shield.
which Blue Cross Blue Shield?
I know. Yeah, I mean,
It's
it's,
azblue.com, and then you just search it under PPO or EPO.
That gives
PPO, well,
them time to
PPO
get
plus.
their stuff.
When?
You just hit to select, I have coverage through my employer, and then it asks you PPO or EPO, you can pick either one of
Yeah,
those,
I'm
and it
gone.
provides
Remember?
all of the
Might have my
cross
niece that
providers,
lives
whether they're,
May or
and
may
it'll
not.
ask you a location that you wanna be looking in, so if you're in Las Vegas or Albuquerque or wherever.
So if our employees were somewhere like that, they can figure it out.
Yep.
Well, you could go to the 24th.
I will not be here the 24th.
Yep.
Or you can pick another day, I mean, it doesn't have to be Tuesdays, y'all.
So while you're all having a nice discussion as part of our agenda, we're up here discussing when
The
we'd
date.
like to meet again.
Mhm.
Considering the holiday, the break, if you will. So I'm sorry, I'll turn it back over.
Okay, well, we need a quorum, so that's the three of us. We have to all be available on the same date. And I have my niece that next
Frank
week
on
after
board
the spring
anymore?
break. I don't know, he hasn't been here.
Is there something we need to do
to
So
get-
we have a quorum, I mean, I understand.
Well,
Doug
Frank
is
won't
sick.
come during the workday anymore, I don't think.
Well, then,
It has
is
to
there a
be
way
like
to
after
replace
5
him?
for him.
So that we can get a
Can we get a
quorum?
different member?
I think your bylaws indicate that you can select a member.
Okay. All right.
As I recall from the bylaws, there's not any specific way to
Right. I
remove
sort of
anybody or
remember
whatever,
that.
so I think you could just decide since you have a quorum, you could decide to replace.
We could extend invitations, that's what we did before. We
There you
would
go.
like decide on someone and extend an invitation to them, to join.
And I'm sure, based on my conversation with Doug, that he would be fine with you saying, okay, Bullhead Elementary District, pick another board member to be on this, because that's who he represents, is our board. He probably would be okay with you saying, you know, could you pick a different board member to be on the committee?
I think we need to hold off on Doug. I think we need to replace Frank.
Okay, and that's fine.
He hasn't been here since.
Well, he just
last
needs an
spring.
alternate. Doug needs an alternate,
Right,
a
and
regular
we can
alternate.
arrange that.
So, yeah, Doug needs a regular alternate. And then, we need another community member, because that's what Frank is he's a community member representative. So, but it's very hard to get someone who'll come during the workday, as Greg well knows.
I can do that. So are we going to do this on the 17th, or are we picking another day? What are we doing here?
I'm not available on the 17th.
Want to tell us when you are?
Well,
Your meeting is the 19th, Carol?
And yeah, our next board meeting is on the 18th.
On the 8th,
Set it
on the 18th, okay.
I have my niece that whole week.
So then the following week, the week of the 23rd and the 27th?
Yeah, it would have to be that week for me because I
Is there
have
any
my
particular
niece
date
out.
that works for either of you?
any day.
The 23rd? Does the 23rd work?
Yes.
I got 2 yeses. And
I have another meeting, but I can skip it.
so okay, so
Is that a meeting every day?
That's a definite maybe. The 23rd
Okay.
works. Is that it?
Yeah.
Again at 4 o'clock.
Okay.
Okay. So the next meeting will be at the 23rd at 4 o'clock. Stephanie, as you promised, we'll get some numbers from you, and we'll sift through everything. Okay. Thank you.
And let's rack our brains on someone we can extend invitations.
And perhaps, and maybe this is not appropriate, I don't know, but would you like these 3 individuals back for that meeting, or do you want to just deal with numbers? What do you
No,
think you might
we do
prefer?
because we may have questions because hopefully that day we're going to pick a health insurance. That's the goal that day.
Yeah, that is pretty much the goal.
And
But
they
we
are
would need
set
to
up a
be
little
known if
differently
we're accepted
Right.
by
that
the
we may need
trust.
to question.
Yeah,
That's true.
we would
What?
need to be known if we're accepted by that trust.
Yeah, that's an application and a governance issue relative to joining the trust, correct?
So we can do all that prior to your March meeting.
Yes.
I can call, and once I get the numbers, and the rates, I can schedule a meeting of the trustees to get their approval or denial, so you have that by March 23rd.
Okay,
Can you do that?
Sure.
That'd be great.
that'd be great. Okay, all right. All right, do I have a motion for adjournment?
So moved.
So seconded, all in favor?
Okay.
All right,
Thank you.
meeting's adjourned.
Yes,
Thank you, everyone.
Representatives and, employees.
Yeah, we'll get a calendar invite.
And I've asked them to mind.
Not happening.